Welcome everyone to the Postpartum Hemorrhage Community of Practice webinar on refractory postpartum hemorrhage. What role can devices play? Before we get started, I want to move quickly to interpretation. Next slide. For our French speakers, please follow the instructions on this slide. For interpretation in English, you click the globe at the bottom of the screen for English, and likewise for French. You can mute the speaker's audio by clicking Mute Original Audio. We'll give everyone a minute to select their language. All right, again, I want to welcome everyone. My name is Sherry Evans. I am a Senior Principal Technical Advisor at Chapigo, and I am one of the co-chairs of the steering committee of the Postpartum Hemorrhage Community of Practice. I'm very excited today to welcome you all to this webinar. Next slide. A few housekeeping before I turn it over to our moderator. Please, if you wish, take the opportunity to introduce yourself right now at the start in the chat box. Please do put all your questions, though, in the Q&A box, because we will have a Q&A session after the presentation. And with that, next slide. There is a disclaimer. The content you're about to see is medically appropriate, but there are some graphic images. The intention is not to offend, but to provide information. So proceed only if you're comfortable with potentially sensitive topics and images. Next slide. It is my great pleasure to introduce Tong Fan, one of the steering committee members who is going to moderate our webinar today and this wonderful panel. Tong, over to you.
Thank you, Sherry. Good morning, good afternoon, and good evening, everyone, and welcome to today's webinar. I am Thuc Phan, and I'm honored to serve as your moderator for this important section. Before we get into today's topic, I'd like to begin by introducing the Postpartum Hemorrhage Community of Practice and reflecting on one of our recent successful events. The PPH Community of Practice is a global learning platform designed to promote the dissemination of evidence-based knowledge and the sharing of experiences between countries in the management of postpartum hemorrhage. Our goals is to support and empower countries to achieve their national and global targets in reducing preventable postpartum hemorrhage through the exchange of both positive and challenging experiences. What makes this community unique is that it brings together diverse perspectives, not only from healthcare providers, but also from women who receive care, ensuring that the real experiences drive the conversation forward. About 2 months ago, we hosted a highly successful 3-day webinar series on placenta accretus spectrum. We were very happy that more than 800 people registered for that series, and we had an engaged audience of around 100 participants in each section. It was a fantastic opportunity to share knowledge and experiences, and it further solidifies the values of this platform in bringing people together to tackle the most pressing issues in maternal health. Building on that success, today we turn our focus to refractory postpartum hemorrhage, a critical topic that remains a significant challenge in obstetric care, I think. This webinar will specifically address country experiences in using the LV balloons and suction tamponade device to manage PPH when conventional methods fail. So now we will move on. We have questions in the Menti. You can follow on the screen to go to the menti.com and enter the code or you can use the QR code. I'm happy to have like a couple of minutes for you to answer this question.
Caroline, could you kindly drop the code into the chat in case people weren't able to get it? Oh,
Yeah,
thank you.
we have codes of 52774605.
For me, it says waiting for the presenter.
Yeah, for me as well. Oh,
Perfect.
yeah.
There we go.
Yeah. So we can go through some responses we have so far. So the definition of refractory bleeding, bleeding that won't stop after 500 ml, continue bleeding after initial care provided, bleeding after first line emotive response. We have not responding to the first line treatment, such as medication, bleeding that continue after multiple rounds of pharmacological treatment and assessment of the women. Yeah. Yeah. So we have bleeding that persisted after intervention, continue bleeding after implementation of the first care bundle. Yeah. Thank you very much for your answer. So we have an exciting lineup of speakers who will share practical insights and data on how the device are being implemented in different settings, what outcome have been observed, and the lesson that can apply across various healthcare systems, particularly in refractory PPH management. By the end of today's section, we hope to equip you with valuable knowledge and tools to enhance PPH management in your own context. I encourage all of you to participate actively in the discussion, ask questions, and share your experiences. This is an open forum for collaboration, and your contributions are key to making this section as impactful as possible. I mean, without further delays, it's my pleasure to introduce our first speaker, Dr. Fernando Anzabe from Argentina. He is currently working as a consultant in the human reproductive programs at World Health Organization. He will be discussing the introduction of refractory PPH. Thank you all for being here. Let's begin.
Thank you so much, Ron, and thanks so much to the organizers, including Sherry, Jennifer, and let's say my co-speakers. And thanks also to the interpreters that will perhaps make even clearer, let's say, my presentation in my non-mother tongue language. So first, a kind of disclaimer. Tuan has well introduced me as a WHO consultant, so I'm mainly a trialist. I used to be a practitioner, and this is a community of practice, let's say, webinar. So I have to tell you that since many years ago, I don't practice. So my introduction will be specifically or mainly dealing with what literature says and what research says. And the most interesting part of this webinar will come from Justus and Gerhard, from whom we will listen, let's say, to both experiences and research, say, evidences that they will present. Having said so, let me tell you what we are going to speak about. Next slide, please. So very briefly, how we define refractory PPH. It's extremely interesting to see the variety of definitions, although there is a kind of a common root, let's say, for most of what I've seen in the from your responses. Then we will very briefly, but mainly for illustrative purposes, we'll comment on the management approach, the general management approach, mainly to illustrate and speak a little bit about the frequency of refractory PPH and also the causes of refractory PPH. And finally, we will go into the role of tamponade devices, and mainly I will remind you, let's say, WHO recommendations and some evidence regarding the timing of using, let's say, tamponade devices. And at the end, I will briefly comment on the red trial that WHO is conducted, and several of us actually participating in this call, in this webinar right now, are participating in this study that is ongoing. Next slide, please. So how we define refractory PPH? First, conceptually, let's say we should say that is, let's say, is a condition in which women with PPH, let's say, ultimately do not respond adequately to the first-line treatment. And that's it, the emotive bundle, or let's say WHO recommendations, in which uterine massage, uterotonics, TXA, IV fluids are, let's say, administered. However, from this point of view, it's incredible that we don't have much evidence about, let's say, about prospective studies using these definitions, because this imply that you have to answer, let's say, the question, if you are screening a PPH or dealing with a PPH, whether or not it responds, let's say, to the first treatment. And what happens usually is most of the studies that report on refractory PPH causes or frequency actually use the second definition, which is guided by the use of the second-line treatment or the invasive treatment. PPHs in which there was a requirement to use these interventions, second-line interventions, including 3 or more uterotonics, temporizing measures, tamponade devices, or invasive surgical treatment, are considered, let's say, refractory PPH. And because of this difference in definition, including also a gray area in which these medical interventions like second, third-line uterotonics, let's say, can be included in the first response or not. And you have seen, let's say, part of this variety of definitions that the audience have shared, in which there is a difference, let's say, on whether these are included in the definition of refractory PPH or in the definition of first response management. Then, let's say, there is a kind of let's say, variation in the rates of and perhaps, let's say, the causes based on that cutoff point, let's say, for the definition. Let's move to the next slide, please. Here, this is a pictorial that we are using for a proposal that was funded by MRC UK a few years ago. And it was suspended, let's say, during COVID, and right now is, let's say, we are working again in this. I think that Sherry can update any of you if you need, let's say, more information. This is what is a kind of a general management from the initial first response management when a PPH is detected to the no response, temporizing measures and definitive measures, let's say, to treat with refractory PPH. Again, I will not go into deep detail about how, let's say, to manage a refractory PPH, but this is useful just to understand the general context and again, try to understand, let's say, the differences in frequencies. The first section, you can see that includes the emotive, let's say, bundle or the WHO first response recommendation, including IV access, uterotonics, TXA, yeah, those are, and let's say, fluids, and together, let's say, with other, let's say, general care, let's say, measurements like, again, using devices, let's say, just to evaluate the let's say, the results of the first response measures, and also some laboratory, let's say, aspect. But without going into much detail, this is the first part in which the first response is done. Then, if it comes to a situation in which this first line treatment, say the woman does not respond to this package of intervention, again, here, whether or not second-line uterotonics, let's say, are included or not, it's a matter that we can discuss later, and perhaps your opinion and Justus and Gerhard's are important on this regard. It comes, let's say, the stage in which, if the woman is definitely bleeding severely and her general status is compromised, again, these interventions are absolutely necessary. These are the temporizing measures in which either by manual compression, aortic compression, or vaginal packs if tears are observed. The anti-shock garment, let's say, definitely a must intervention, let's say, to use as temporary measures until you move to a place or to a kind of let's say, more specialized, let's say, assessment and treatment can be done either at an operating room, or in some places, let's say, could also be the delivery room. It depends definitely on the resources that are available at each of the different facilities. At that time, definitely what you will finally make is from a presumable initial diagnosis to a kind of a more certain diagnosis and a decision to what kind of, let's say, cause is actually generating the refractory PPH, whether it's tears, whether it's atony, or whether it's retained placenta. Let's see a little bit about numbers. What do we know? Next slide, please. So, if we take all the PPHs in a retrospective study using the second definition about the use of, let's say, what were the PPHs that required the need of these second-line interventions and, let's say, or temporizing measures or surgical interventions, it came out that 16% of the women, in fact, let's say, had this refractory PPH. But this was done considering that the definition of PPH, the initial population of PPH, were women bleeding, either bleeding more than 500 mL, or women in which additional uterotonics were used to treat, let's say, excessive bleeding. You can see, for example, in the, let's say, we are conducting the red trial. I will, let's say, later explain you about this, but for now, or by now, what is important is that this is a prospective study in which we are screening all PPHs. So we know from the very beginning which cases actually respond well or do not respond to PPH. And in the overall, let's say, and all these women, in fact, bleed more than 500 mL to be screened. So if we then take only women that initially bleed more than 500 mL, then you can see that the proportion of women not responding to the initial measurements, to the initial first-line measurements, are actually higher. So I would say that right now, let's say the variation can be between 15 to 30% according, again, what are the definitions you use, let's say, for both refractory PPH and the population in which you are defining, let's say, or how you are defining PPH at first point. We have very good data in RED trial that in women in which atonic PPH is suspected, definitely we know that 20%, approximately 20%, in fact, do not respond to the first line and second line uterotonics in women who bleed more than 500 mL. Why this is important, let's to know, and I definitely push you, let's say, to try to take a look even prospectively in your own, let's say, facilities to do this. Should not be complicated to do that, because the distribution of resources, training, and awareness, let's say, in part depends on the frequency that you will see, let's say, these problems appearing. Next slide, please. Then when we look more closely to the subpopulation of women with refractory PPH, what are the causes? This is coming from two retrospective studies. One is the one we did with Champion, and another one is from Musa, published in, let's say, more than 15 years ago. But there is, again, very limited evidence, let's say, in the literature, as far as I know. What we can tell is that, look, approximately 1 out of 10 will be, let's say, retained placenta products. Okay, that in the general population of PPH is perhaps, let's say, less than 1% or around 1%. But atony would, let's say, and the rest of the 90% or 9 out of the 10 cases distributes half and half between atony and tears. And why is this important to understand? Because right now we are going to focus on what we do on refractory, atonic refractory PPH. But it is as important, or perhaps even more important, what happens with, let's say, this half about tears, because the resources perhaps and the skills that are necessary to deal with this complex situation of tears is perhaps much more challenging than the use of the devices, or at least, let's say, in a similar situation. And let's not forget, let's say, that in some way the approach for a refractory PPH should be considered as an integral, say, or integrating all the causes, and again, distributing the resources, the skills, and the training to deal with all the three causes, but mainly these two that are the most, let's say, prevalent ones. Let's move then to next slide, please. The role of tamponade devices. What I would repeat right now and remind you is what WHO has or actually recommends right now, currently recommends, on uterine balloon tamponades for treating postpartum hemorrhage. This was an updated recommendation done in 2020, published in 2021, and it says that UBTs are recommended for the treatment of postpartum hemorrhage due to uterine atony after vaginal birth in women who do not respond to standard first-line treatment, provided the following conditions are met. The following conditions are specifically dealing with settings with good resources for immediate recourse to surgical intervention, where a primary PPH first-line protocol, let's say, is available and it's routinely implemented, where you can definitely exclude other reasons, let's say, for of PPH. Again, remind you this issue about tears and placental problems, where you have trained personnel and where the maternal condition can be regularly and adequately monitoring for prompt identification and signs of deterioration. In other settings, in low research settings, or lower research settings in which these conditions cannot be ensured, still the use of UBT is recommended to be done in the context of research. And why is that? Well, mainly because the evidences supporting the use in these low resource settings, let's say, are the best evidence that we have are coming from 2 trials that showed, let's say, some safety concerns. But definitely in where you can, let's say, provide some minimum level of good resources, summarizes here, definitely, let's say, uterine balloon tamponades, mainly, and perhaps, let's say, right now, other kinds of tamponade devices, as we will hear, can and should be used to treat atonic refractory PPH. Next slide, please. One thing that usually comes to a question is, okay, look, when we should use the UBTs. And again, we will hear a lot coming from Justus and Gerhard, but let me tell you something that was published about 1 year ago, less than 1 year ago. This was a trial conducted in France by Rosenberg and colleagues, in which they randomized almost 400 women with refractory PPH, very freely defined refractory PPH, first-line treatment, let's say, not responding. And they used they randomized the women to receive a UBT. It was the EBB, let's say, UBT, used in combination with the second-line uterotonics, or after the failure of the second-line uterotonics. It's like, again, using kind of a different moments to, that can be different moments to use the UBT, or also different moments to define refractory PPH in some way. What happened then? No? And they evaluated as the primary outcome the rate of severe PPH, including by blood loss measurement and the use of more than, I think, 3 units of transfusion, of blood transfusion. They found no statistical difference between the groups. The difference was slightly in favor, again, although no statistical significance in favor of the use of early. But the conclusion of this group is that, in view of the evidence, let's say, so far, there are no reasons to anticipate the use of the devices and try to use them, let's say, when the second-line uterotonic treatment perhaps is failing, until, let's say, more research is done. Next slide, please. What type of device? I will not go into much comment regarding this, because in the WHO recommendations in 2021, let's say, answering these questions, in fact, was part of the recommendations for research, the research implications in the, let's say, in that guideline. And specifically, we say there that the questions about what is comparative effectiveness of different types of UBT devices, including improvised or low-cost purpose-designed devices, like the ELAVI, for example, in the reduction of PPH-related maternal mortality and morbidity and mortality. And also, what is comparative effectiveness of UBTs compared to other tamponade interventions? So since we published this, you will see, let's say, some research that has been done, let's say, by my next two co-speakers. And also we are conducting, next slide, please, the RED trial. The RED trial is an adaptive hospital-based multi-center, multi-arm, multi-stage, individually randomized active control superiority trial, in which we are evaluating the efficacy of different tamponade devices for the treatment of refractory PPH. In fact, what we are comparing is 4 arms. One control arm with an improvised UBT, which is the Foley catheter. This is used in Vietnam, where the trial is right now ongoing. And we compare this to the suction tamponade device that Justus will comment, and with the Elavi UBT used in 2 different ways, fixed volume or free flow. And the first interim analysis, in which we will orient whether or not to continue this study into a second phase after defining the best performing device, is right now ongoing. I think that this week we have reached, or we are going to reach, 500 women already enrolled, which makes this trial the largest trial ever randomizing women with different tamponade devices. And we hope that in about 6 months, we are going to arrive to 690 women and conduct, let's say, this interim analysis and decide the way forward. So nothing else from my side. Thanks so much. I will welcome, let's say, your questions after the rest of the presentations.
Thank you so much, Dr. Fernando and Tabe, for that insightful and informative presentation. I think that your experience and expertise have certainly provided us with a deeper understanding of refractory PPH. We truly appreciate your contribution to today's section. Now, it is my pleasure to introduce our next speaker, Professor Justus Home. He is from the University of Botswana in South Africa. And he will be presenting on the implementation of the suctionative uterine tamponade in PPH treatment. Please join me in welcoming Professor Justus Home.
Thank you very much, Tuan, and good day. And thank you for the opportunity to talk about suction tube uterine tamponade. I'd like to acknowledge many colleagues who've worked on this, and particularly Mandisa Singata Madliki and Dr. Alvaro Nieto Calvache, who I think is on the webinar today. I just need to see if I can advance this slide because it's very unclear. Yes. So I'll try to go fairly quickly through this. To place suction tamponade in the context of the continuum of care to prevent and treat postpartum hemorrhage, I'll briefly discuss blood loss monitoring after birth, then the tamponade devices, then what evidence we have to date, and then how to implement what we know. In the emotive study, we showed that quantitative blood loss after birth is absolutely critical to achieve early bundled first-line treatment to reduce progression to severe PPH. And in that study, we used the brass V drape, the calibrated drape. But for long-term implementation, this does have problems because it does depend on very good procurement processes and ongoing funding to keep replacing these drapes. And for that reason, we have developed a reusable device for measuring blood loss after birth, which has the advantage that it doesn't require ongoing investment for sustainability because it really can be used for many, many years. A randomized trial of the maternal drape, and I'm happy to see that Dr. De Waart, who supervised this project is in the meeting today. A small randomized trial was done comparing the brass V drape with the maternal well tray, and both were really highly acceptable both to midwives and to mothers. The one difference that was found was that the drape was more likely to underestimate the amount of blood loss, which is to be expected, because with the tray, the blood collects directly into the calibrated well, whereas with the drape, it tends to pool around the mother and needs to be swept into the calibrated V. We've recently published that possibly the term active management of third stage of labor should be dropped because it means different things to different people, and we should focus on the term third stage care, including only evidence-based methods. So we emphasize, first of all, birth in a non-supine position, and then we use the mnemonic BOND, which is baby skin to skin, oxytocic, N is initiate blood loss monitoring, and then D is for delayed cord clamping, which is important to avoid childhood anemia in all children, but for preterm babies, it's actually a life-saving procedure. And as you can see, any blood loss after the birth collects directly into the maternal well tray, and if the first well overflows, that indicates blood loss of more than 500 mils. So what about tamponade devices? As Dr. Altabe mentioned, even before, yes, we've got really good evidence today that early diagnosis is critical and that early bundled treatment of the motive bundle is highly effective at reducing the risk of major postpartum hemorrhage, about a 60% reduction. But if that fails, we need to consider uterine tamponade. As Dr. Altabe mentioned, WHO currently recommend balloon tamponade. There is some concern about this because the two randomized trials published to date, but I would emphasize these were trials looking at condom balloon tamponade. The improvised condom balloon tamponade found that those in the control arm with no tamponade did better than those who received the condom tamponade. So we do need to be thinking about alternative forms of tamponade. The one is more efficient balloons, and Professor Theron will be talking about that. And the other is the complete opposite approach, which is suction tamponade, which is quite an attractive approach to clinicians because it focuses on sucking down the uterus, just as we do when we do manual vacuum aspiration to contract the uterus and constrict the blood flow. The JADA device is registered by the FDA for treatment for postpartum hemorrhage. There have been two observational, not randomized, large trials in North America comparing the JADA device with the Bakri balloon tamponade device, and both of those found the JADA device to be considerably more effective than the balloon tamponade. However, the JADA device is unaffordable in our countries at about $1,200 for each device. So for many years now, we've been improvising with various simple balloon suction catheters. Most commonly, we use the Levine stomach tube FG24, which costs about half an American dollar, about 50 American cents. We insert that to the fundus of the uterus and apply suction with 100 millimeters of mercury. And that suction immediately fixes the suction tube in the uterus. And because it's a negative pressure, the uterus and vagina just suck down around the tube and form a highly efficient seal. And we've published a feasibility study in 45 cases, a small case series in patients with catastrophic postpartum hemorrhage, and one acceptability study. So this is to show the relative sizes of the 24 gauge suction tube tamponade, and at the bottom, the the Jada device, and close up just to show the apertures in the Jada device and those in the suction tube tamponade, through which the aspiration of fluid from the uterus and the negative pressure is generated. So I'm grateful to Dr. Nieto Calvache for these videos showing that for use of the suction device, because it's a simple, smooth tube, it's really very easy and comfortable to insert for the patient. It can either be inserted manually like this or visually with a speculum and with a swab holder. And here you can see that the tube has been inserted right to the fundus of the uterus. Once bleeding has stopped, what we do is we disconnect the suction, but leave the tube in place for 15 minutes to see where the bleeding will start again. If it does, we simply reattach the suction and continue for another hour. And then every hour we will disconnect suction and see whether the suction is still needed. Once the bleeding has stopped, then again, it's very, because it's a simple tube, it really slips out very easy and very easy to remove. So what evidence do we have to date? As Dr. Althabe mentioned, and I mentioned earlier, there's actually very little robust evidence on any method, mechanical method of treatment for refractory postpartum hemorrhage. Very recently, there was a small trial from South India, randomized trial, in which it was shown that both suction tamponade using a simple a stainless steel suction tube and transvaginal clamping of the uterine arteries were significantly better than balloon tamponade with a condom balloon with respect to the need for a second line instrument, in other words, failure of the first line instrument, and also with respect to the time to hemostasis. We've recently completed a small exploratory randomized trial at 10 sites in South Africa and a tertiary referral center in Colombo, in which women with refractory PPH were randomized to the simple suction tube tamponade with the Levine tube, or to balloon tamponade with various devices, mainly the Bakri balloon and the Elavi balloon. And the primary outcome, which was blood loss greater than 1,000 mils, or laparotomy or death, was reduced by 40 to 50% in the suction versus the tamponade group. And this difference was statistically significant for the per protocol analysis, but was not statistically significant in the intention to treat analysis. But what was most important is that, and this is to be expected because the suction tube is a very simple, smooth tube, easy to insert compared with the slightly more bulky balloon, which is then inflated and causes pressure in the uterus. When we asked the women about their experience of pain, significantly more women in the balloon tamponade experienced severe pain during the procedure than with the suction tube. And I do think this is an important aspect of these tamponade devices, because they certainly are not painless devices to use. So if we put together the data from the study in India, from the part of our study in Colombia and the South African arm of the study, the effect on the outcome blood loss, 1,000 mils or laparotomy or death, was very consistent between the three, and meta-analysis of all the data together showed a reduction in severe blood loss of about 34%, which reached statistical significance. So I'd emphasize that these are very small trial data, and that our trial has not yet been subjected to peer review. But I'd like to suggest that at this stage, and until we get the definitive answer from the RED study, which Dr. Althabe spoke about, I'd like to suggest that the balance of evidence we have so far is in favor of suction tamponade over balloon tamponade in general, and particularly over the improvised condom tamponade, where there's quite strong evidence against its use. How do we implement this information in Princess Marina Hospital in Gaborone in Botswana? We've implemented a quality improvement project with training of staff in all the techniques. And we have these posters up in every labor ward to remind our staff of the importance of paying attention to postpartum hemorrhage. It's something which has to be at the top of our minds, because after the birth of the baby, there's a tendency for everyone to relax and think, well, everything's fine. We need to be vigilant in the third stage. And so we recommend our approach to third stage care: baby skin to skin, O for oxytocic, N for initiate blood loss monitoring, D, delay cord clamping. And then carefully monitoring for blood loss. And if blood loss is 500 mils or more, rapidly instituting the motive treatment. And if that fails, examine for the cause. And if bleeding is from the uterus, not to delay, not to wait for bleeding to get to 2,000 and 3,000 mils, but to quickly use a tamponade method. And when suction tamponade is available, we would use that. And so in summary, we'd say that for third stage care, we suggest the use of a simple mnemonic bond to remember all the evidence-based steps, to emphasize the need for measuring the blood loss as best as you can with whatever method you have available to you, to promptly use the motive bundle as soon as there is any evidence of postpartum hemorrhage, and for refractory PPH also to not delay before instituting whatever form of uterine tamponade you have available to you. Thank you very much for your attention.
Thank you very much, Professor Justus Ome, for sharing your valuable insights and experience with us. Your presentation on the suction tube uterine tamponade device was truly thought-provoking and gave us much to reflect on in terms of the improving PPH management. Next, we have Professor Gerhard Serong, who is from Stellenbosch University in South Africa. He brings a wealth of experience in refractory PPH management, and he will be discussing the implementation of LV balloons in the PPH management. And I'm excited to hear his perspective. Please join me in welcoming Professor Gerhard Serong. Hello, Gerhard.
I cannot unmute. Okay, I'm sorry. Did you unmute me, Tuan? I couldn't do it myself. Tuan, thank you for introducing me, and I want to thank the organizers for the focus of a webinar on refractory postpartum hemorrhage. I really think that's so important, because I think that's where the case fatality with postpartum hemorrhage happens, is when it's refractory. The risk of death is often very high. I will discuss the development of the Ilavi uterine balloon, as well as the studies, the case series we conducted with this product. I want to acknowledge the help of the co-authors listed there. Mavina Johnson was responsible for the midwifery study. She sadly passed away a couple of years ago, and then Vulikaya Mpumwana was helping me with the study in the regional hospital, a deep rural regional hospital, and then Taslim Hassim from our department for the volume shifts that occur with Ilavi use. The next slide, please. I have no conflict of interest. I have not received any remuneration from Sanapi or hold any appointments with the company. Next slide, please. We became aware of the use of uterine balloon tamponade in the management of postpartum hemorrhage when Bakri published a case series in 2001. This was a case series of 6 women. 5 of them had low-lying placentas or placenta previa, and 1 with a cervical pregnancy. Uterine balloon tamponade gained acceptance quite rapidly and became used either as a commercial device or with makeshift devices. Next slide, please. The question always is, can it cause harm? And I think there is one particular complication that must be pointed out, because you can think that using compressant sutures when indicated and with ongoing bleeding following compressant sutures, the chance that you will arrest this bleeding by adding on uterine balloon tamponade is quite good, and then it avoids further surgery on a woman that's at that stage lost a lot of blood and possibly not coagulating so well. However, if fixed volume devices are used, the pressure inside the uterus actually can cause harm. And the figure that you see there was a woman with refractory postpartum hemorrhage with B-Lynch sutures inserted with ongoing bleeding, and a rush catheter was inserted. The bleeding was arrested and the woman was actually discharged, but later to be admitted with an acute abdomen, and at laparotomy, there was necrosis of the fundus of the uterus that required a hysterectomy. So it's very, very important, if this combination is to be used to avoid this serious complication, you must use a balloon where you can control the pressure inside the uterus. Next slide, please. Now, we decided to rather use a surgical glove and not a condom. If you snip the middle finger and you tie the part where your hand goes in, you can see when inflated and you ignore the fingers, you actually have a very nice balloon. And if this is now connected with a giving set and IV fluids and it's left open, it fills up rapidly and you can actually control the pressure, as I'll explain later. This was described in a monogram in 2010. Next slide, please. No, you're going the wrong way. The surgical glove balloon has 2 unique features. It allows pressure control. The specific gravity of mercury is 13 times that of water. And the aim is to have more or less systolic blood pressure inside the uterus to stop the bleeding from the placental bed. And say the patient has a systolic blood pressure of 100 and your intravenous bag of fluid is 1.3 meter above the patient, you know you've got 100 millimeters mercury pressure inside the uterus. But there is a very important prerequisite, that is that the balloon must be able to fill up large enough without requiring expansion pressure. Otherwise, your formula does not work. The second large unique feature is that it's a free flow system. In other words, your aim with the management of postpartum hemorrhage due to atonic uterus is to facilitate contraction and retraction. And because it's a free flow system, fluid can be expelled from the balloon inside the uterus back into the bag, supply bag, thus making the balloon smaller and facilitating contraction. So this is a very, very important and unique feature of an open flow system. Next slide, please. I then realized it's important to have a commercial unit available based on the principles of the glove balloon, and I challenged Sanapi to design a balloon as a single unit with tubing and a supply bag, a T-valve in the tubing, and with a balloon that's cylindrical in shape, with a capacity of 750 milliliters that fill up to that capacity without requiring expansion pressure. Next slide, please. It became a combined effort of various groupings, all listed here. Next slide, please. And there's the end result. The supply bag, the tubing, and there's a T-valve in the tubing. And of note is that the tubing distal to the T-valve, the shore hardness of the tubing was increased with 40%, which facilitates the placement and it prevents the tubing from being kinked. The balloon itself were manufactured from thermoplastic elastomers. The product has a CE marking, and I got news this morning that it's also now FDA registered. Next slide, please. Now, we had to consider the need for a drainage port, and the need for a drainage port is questionable. The ports are small, usually about 2 millimeters in diameter. It's easily kinked or blocked with blood clots. The fact also is that the placental implantation site compromises about 20% of the inside surface of the uterus. And if your port is not in proximity to this implantation site, drainage through the port is unlikely. And what we learned in practice is if there's ongoing bleeding, it's excessive. It exceeds the capacity of a small port, and it's obvious that blood is escaping past the balloon from the vagina. It's also very important to act on ongoing bleeding, and therefore time is very important. You have to act rapidly, and the advantage of the Elavi balloon with the supply bag is that it fills up to 750 milliliters in 45 seconds. In one of the midwife obstetric units, a midwife actually timed the filling up of the balloon when we demonstrated it, and it was 37 seconds. Now, and that allows a rapid assessment of whether the bleeding is reduced. And we definitely would suggest that after filling the balloon and the bleeding is not really definitely reduced within 15 minutes, you must continue with the next step in your management bundle. So it's very, very important that you work according to a management bundle, and if the one step fails, you proceed to your next step. Next slide, please. Now, a new device requires scientific assessment, and we are all experts in this following the COVID pandemic with the vaccine studies, but with devices, it's a bit different. So case series is usually the way to go, and I thought to do 3 case series at the 3 levels of obstetric care in our country, that at specialist level, in an academic or central hospital, that in a rural regional hospital without specialist cover where medical officers have to manage the patients, and thirdly, in a midwife obstetric unit or a small district hospitals where the midwives work on their own without doctors available. All patients that had placements in the 3 case series, the person that did the placement were interviewed with in a structured format to get information back about their experience of the use of the device. These were all feasibility studies done by intention to treat. And the 4th study that was also important is to actually measure the volume shifts that we saw were happening in the supply bag. The volume increases during use, and we were not sure how big these volume shifts are and whether they actually occur. And then ultimately, and that's where Fernando explained, there will be a large randomized control trial, which is multi-arm, multi-stage, and multi-center. And that's ongoing at this stage. So that's the final step in the assessment of a device. Next step. Next slide. So the specialist case series was done in Tygerberg Hospital, which is an academic hospital with 3 close by district hospitals that feeds directly into the hospital. During the time period shown there, the number of deliveries during that time was 29,000, and 20 cases were included in the case series. So you can see that recruitment is usually quite slow, and it's not so easy to get to your numbers of patients. Next slide, please. Now, 19 placements were done, and in 15 cases it was successful. Next slide, please. Then in the deep rural regional hospital, which is the St. Elizabeth's Hospital in Sikisiki in the Eastern Cape of South Africa. The study period is indicated, and the annual number of deliveries in this hospital is just over 5,000. The total number of patients included in the case series was 10. Next slide, please. And in 9 of those, the bleeding was curtailed or stopped. All patients were referred to the next level of care, which is the tertiary hospital about 2 hours drive away. All the patients arrived there safely, and all patients survived. Then we came to the midwifery study, which was done in 6 midwife obstetric units in the Cape Metropolitan area. During the period shown there, the total number of annual deliveries in these 6 units together is close to 10,000 deliveries, and the total number of patients included were 12. Next slide, please. So in 10 cases, placements were done, and in 8 of the 10, the placements were done by midwives, and all 8 were successful. So it's definitely a procedure that can be done by midwives, and the advantage is it gives them an additional measure of managing their patients, and all their patients, of course, always will be referred to the next level of care, and this makes the referral much safer. So I differ from Fernando in this regard. I think if you do studies on postpartum hemorrhage, the setting must be there to provide the full scope of treatment. But the site where the study is done need not necessarily have that all those facilities, because the patient will be referred to that level of care. And we also need to make the referral of the patients safer. When we look at our National Confidential Inquiry into Maternal Deaths in one triennium, there were more than 600 maternal deaths due to hemorrhage. Of those, more than 120 patients had to be transferred from where they delivered to the next level of care. And of the 120 women, 20% died while waiting for the ambulance, and a further 15% in transit while being transported in the ambulances. So we must make the referral of the patients safer. Next slide, please. So we learned from these 3 case series that insertion is feasible, that the health professionals prefer a pre-packed single unit, and that the filling of the balloon and the management of the patient according to the systolic blood pressure, controlling the pressure, was done correctly. The overall success rate was 85%. These case series include 13 patients that were delivered by cesarean sections. No complications actually occurred, and all patients had a good outcome. Next slide, please. Now, the last study was to look at the volume shifts back into the supply bag, as these shifts has not been quantified, and then also to assess a measure that will facilitate expulsion of water from the intrauterine balloon. And this was also a case series. Next slide. Conducted this case series. We decided to include 12 consecutive patients, which all had the larvae inserted and were managed in the obstetric critical care unit at Tygerberg Hospital. In Group A, the patients, the bags were measured every 30 minutes. And in group B, the bag was lowered by 50% at whichever height it was. The uterus were gently massaged for 30 seconds, and then the bag was replaced at its original height. The T-valve was closed during weighing, and the bags were weighed with a sensitive digital scale. Next slide, please. These patients all had severe hemorrhage requiring blood and frozen plasma. All the patients had the height adjusted according to systolic blood pressure every 30 minutes. And in group A, the duration of uterine balloon tamponade in the uterus was 24 hours, which is the standard across the globe when uterine balloons are used. After 24 hours, it's removed. But in group B, it was significantly less, 11 hours. With regards to expulsion, none occurred in group A, but in group B, 5 expulsions occurred. Next slide, please. So it was quite clear that the facilitation of uterine contraction and retraction actually resulted in expulsion. In other words, the uterus regained contractility better with this measure. The number of weight measurements were about 90 in both groups, and the amount of fluid in the supply bag of the patients in group B were borderline significantly higher, about 133 mils compared to 24 mils in group B. So clearly there were more fluid expelled from the uterine balloon. Next slide, please. Our conclusion is that we have proven that water is expelled from the intrauterine balloon, and that more water was expelled when there was a measure taken to enhance the contractility of the uterus in group B by lowering the supply bag every 30 minutes. Next slide, please. All 4 of these studies were published as peer-reviewed papers, and the references are shown on this slide. Next slide. Next slide. There were 2 important lessons that we learned. The first one was that women do experience abdominal discomfort, not always, but a lot of women, once the balloon has been inflated, and that probably will apply to any uterine balloon. But by lowering the balloon halfway and gently rubbing up the uterus and allowing water to flow back into the supply bag, in all cases, the discomfort is relieved. So there's a very simple measure, a measure that can manage this abdominal discomfort. The next slide. One of the problems with uterine balloons, again, it will apply to all the balloons, is expulsion of the uterine balloons. And doctors often become concerned if the balloon is expelled. And it's very, very important to note that if the balloon is expelled with no further excessive bleeding, the problem has been solved, and there's no need for reinsertion of the balloon. And the balloon will usually be expelled when the uterus contracts and retracts. That also solves the problem of bleeding from an atonic uterus. If the balloon is expelled and there's ongoing excessive bleeding, uterine balloon tamponade has failed, and there's no, it won't help to try a reinsertion. You must continue with the next step in your management bundle. Next slide. Thank you very much. And I think during the discussion phase, if there's any questions, it will be discussed further. I thank you.
Thank you very much, Gerhard, for your presentation. Your insight into PPH management and LV balloons were both informative and inspiring, and I'm sure that everyone gained valuable takeaway from your talk. So before we move into our Q&A section, so we'd love to hear from you. We prepare a quick interactive poll using Menti again to gather your thought on the topics, please go to menti.com and enter the code to participate. So take a moment to share your thoughts and we'll take a look at the results together. Once again, that's menti.com with the code 52774605. We'll give you a minute to submit your responses. And then we'll dive into the question. So far we have 11 participants to join us. I think we should give like 1 more minute for all of us to submit the response. Okay, thank you very much. So far we have like 17 participants, over more than 100 participants today joining in our webinar. So we see like most of us vote for the balloon tamponade. Yeah, 11 choose balloon tamponade. So maybe afraid that we require more of the information from the balloon tamponade or the suction tamponade. And now we're moving to the Q&A session. I would like to introduce Dr. Sam Mongons, who will be a moderator for the Q&A section. Hi, Sam.
Thank you so much, Thon, and good morning, good afternoon, and good evening, everyone. And I want to take this opportunity, first of all, to thank Professor Gerhard and Professor Justus Hofmeyr and Dr. Fernando for the excellent presentation they have given us. There's a lot of learning and a lot of more questions they have raised in the presentation. But now it is our time now to ask some questions. Ask any question to these wonderful speakers. And if you have any question, please raise up your hand. We shall unmute you. But if those who are unable to unmute, you can type your question in the Q&A. I would like to appreciate the questions which so far have come. And when any hand comes in, I should be able to take those questions. So there's no hand yet. We shall straight away go to the ones which have been posted in the Q&A. And the first one is, how does the suction tube seal without an inflatable collar work? Can the suction be used as zero section? I did think this question is directed to Professor Justus Hofmeyr. You can take on and answer that question.
Thank you very much for that question. It's interesting because it's quite sort of counterintuitive to think that you don't need a seal. But the reason is that because we're using a negative pressure in a system which is very soft tissues, the uterus and the cervix and the vaginal tissues, as soon as there's a negative pressure, these tissues all suck around the tube. And really, in now hundreds of cases that we've used, that there's no problem with leakage because of that negative pressure sucking on the tube. I think those of you who are familiar with doing manual vacuum aspiration of the uterus for evacuation of the uterus know that once the suction tube is in, one gets a seal, and there is no cuff to seal it. So I think it's just sort of a law of pressure, that when you have a tube surrounded by soft tissues and a negative pressure, those soft tissues form a very effective seal around that tube. Regarding use of cesarean section, yes, absolutely. And in the, well, I'm now talking about the JADA device. They did a follow-up study after registration of the device in 800 participants in 16 hospitals in North America. And of those 800, 270 were used at cesarean section. And the success rate was 84% in the cesarean section group, and I think 94% in the vaginal birth group. And our initial study with the suction tube was actually done with placement at cesarean section, not after cesarean section. So at cesarean section, we simply passed the open end of the tube retrogradely through the cervix and vagina. An assistant under the towels connected that to suction. So the tube was in the uterus. As soon as the uterus was closed, one then had a closed unit and the suction became effective. So thank you very much for that question.
Thank you, Professor Justus Hofmeyr, for that excellent response. I hope we have captured it. The other question was the use of uterine balloon by midwives has already been explained by Professor Jahad, but I want to go to the next one. But in the case of uterine tears, that's non-atony, what about the focus on the role that temporalized bleeding itself can have in order to prepare or transport the patient to the next level? I will invite Fernando to try to answer that question, or any other presenter of the three be able to answer that.
Yeah, thanks. I think that this is an interesting question. I'm not sure whether just talking about other measurements to deal with other causes like tears, let's say, is we need to discuss this at this let's say at this moment. I cannot tell you, let's say, very practical experience or literature regarding that, because we haven't reviewed that. But so far, definitely, let's say, vaginal packing, aortic compression, and the use of the garment are the temporizing measures mostly recommended for deal with mainly trauma, let's say, causes. And of course, say the use of a second, let's say, dose of TXA, as well as for all, let's say, PPHs. Justus probably, let's say, will have a better answer than me.
Justus, you want to give in some input there?
Thank you. Of course, tears may be at any level from the vagina to the cervix and to the uterus, but I understood the question to be uterine tears, so tears in the uterus itself. And there, of course, at laparotomy, one tries to control those with direct suturing. But if that fails, we recommend that before wasting any time and losing more blood, one applies a Foley catheter uterine tourniquet, which is an extremely simple thing to do at laparotomy, simply taking a rubber Foley catheter, slipping it over the fundus of the uterus, right around the broad ligaments, crossing it in front of the lower segment behind the bladder, pulling it very tight and putting a little clamp on it. And that gives complete hemostasis of the whole uterus. If it's pulled tight enough, there'll be zero bleeding. People use this a lot also in doing myomectomies. And then if the bleeding can't be controlled at the level of hospital, for example, there's not the skills to do a hysterectomy, the patient can be closed with that tourniquet in place and transferred to a higher level of care where she can be reoperated and the definitive surgery done. So we really recommend junior doctors at a peripheral hospital. It's not difficult to apply a uterine tourniquet to control bleeding from the uterus, whether it's from the placental site or from tears, until such time as definitive treatment can be given. The other methods that have been used and I think are underused is clamping of the uterine arteries. And this can be done both during surgery, just with clamps. And there are 2 randomized trials showing the effectiveness of this, where there are special clamps, but we just use swab holding forceps or put over the broad ligament on each side and just catching the lateral part of the myometrium to clamp the uterine arteries on each side. Or if it's not at laparotomy, then applying what I referred to in the study from South India, the transvaginal uterine artery clamps, where again, we just use swab holding forceps transvaginally. We put one on the cervix, pull the cervix down, and then place a clamp up above the level of cervix on the lateral side of the uterus where the uterine artery tracks up. And one can get quite good control of the bleeding with those as well. So we have many practical techniques. The thing is to try and stop the bleeding quickly, with whatever, whether it's direct pressure, whatever you can do, stop the bleeding quickly, while then you resuscitate and try and get permanent control of the bleeding. Thank you for that question.
Thank you so much, Professor Justus. I think that is adequate for that. There's another question about the use of heat-stable carbetocin for treatment. Maybe I'll give this to Professor Jehad. What is your experience, or what evidence exists?
Yeah, no, I just wanted to perhaps just respond on the previous question that that we do have some experience in temporizing the bleeding with tears using tamponade while the patient is being prepared to be taken to theatre, and while the patient is prepared. Often there will be a little bit of a waiting time for the consultant to arrive to do the hysterectomy. And so definitely also you can temporize blood loss by putting in a uterine balloon tamponade if there is bleeding, arterial bleeding from a tear. But this is not it's only to temporize before the definite treatment. Now, unfortunately, carbetocin is not available for use yet within the public health sector in South Africa. I think we are excited about the prospect that it may become available, because it's not heat. You don't have to refrigerate the product. However, I think everybody was waiting for the randomized controlled trial, and then ultimately the result came out, and it actually doesn't work any better than oxytocin. But our concern, of course, is that oxytocin may not, if it's not kept refrigerated, may not be as effective as it should be. I think that's the important point. But the randomized controlled trial that was published did not show any advantages over the use of oxytocin.
I think WHO is planning another study for treatment, but hopefully we shall keep our ears on the ground to when those results finally come out, especially the heat-stable carbetocin for treatment. But as you mentioned, WHO evidence says it is only for prevention currently. We have several questions, and we're running out of time. But the next question is for Professor Justus. With the suction tube uterine balloon, do you have issues with the clots blocking the whole of the suction tube? And then you will take it together with the, why do you think that the suction device is doing better than the uterine balloon tamponade, according to the results you have just presented? If you could answer both of them at once, that would be lovely.
I'll try and be very quick. It's very rare, but we have had one case where the tube was blocked with clots, and then either one can just flush it with a little bit of saline or remove and putting in a new tube. But it is unusual because there are multiple pores in the tube. So if one pore were to be blocked, there would still be many other pores which would allow the suction to take place. As far as the second part of the question was So just remind me.
The second part of the question, why do you think that the
Oh yes,
suction
why is
is
it
doing
better?
better?
Well, it's. I think we don't have the definitive answer yet. We're waiting for that. But in the theoretical advantage of suction tamponade is that it reduces the volume of the uterus right from the start. And we all know that the mechanism of hemostasis of the placental bed is the passage of the spiral arterioles through the lattice work of myometrial fibers. So as the uterus contracts down, those fibers actually physically close off the spiral arterioles and stop the bleeding. So negative pressure sucking down the uterus has a very direct effect on that constricting effect. The mechanism of balloon tamponade is more a pressure effect on the bleeding site. And so they are different mechanisms. And so far I've suggested that our results so far suggest that the suction method may be more effective, but we'll await the definitive results of the RED trial to be more certain about that. Thank you.
Okay. Thank you so much, Professor Jesmond. There are several questions. We might not exhaust all of them. We shall try to respond them and then share it together with the presentation after this, or if you have registered and your email is indicated, this presentation will be shared and then also the response to them. But I think we still have about like 3 minutes. There are questions related with the external aortic compression during refractory PPH to gain time for applying the device. I'll ask Fernando to comment briefly on that, and the rest of the question we shall give responses and post it together with the presentation.
Sorry, Sam, can you repeat the question? I'm trying to read it, but
the question, the use of external aortic compression when you are applying the temporalizing device in order to arrest the bleeding, to reduce the blood loss. How is it something which is applicable?
To be honest, I don't have definitely experience in doing that other than a few cases, and I haven't reviewed, let's say, the literature. So I would say definitely yes is one of the recommendations, but those recommendations are not based on hard evidence. I would let's say thank or be grateful to Justus or Gerhard if they want just to comment on how they apply, let's say, this, and which are the cases in which definitely let's say aortic compression has a kind of a clear indication of things.
Thank you, Fernando. Our time is overspent, but just briefly some key takeaway messages which we have picked from this. We have had the definition of refractory PPH, which is clear that anything PPH requiring a second-line treatment, we need to consider it as refractory PPH. And secondly, we need to prepare for about 15 to 30% of the women may experience secondary PPH, and we need to act faster. And the more important thing is also that the distribution now of the causes of PPH is between tears and atony. So it is important for us as clinicians on the front line to be having skills, but also devices to arrest in such cases, because if you can't clamp a tear or stop bleeding from a tear, that woman is likely to bleed as you wait, basically transferring to an ORT or the next level. The other lesson is the importance of objective measurement of PPH using the DREP. And now Professor Hofmeyr has brought in more interesting option of care, that is the bond, which is something we can apply and test and see how applicable it is in our settings. So, and the other lessons, there are many lessons, but I would like to stop here and thank you for staying up to this period and sending those interesting questions. It shows how interested you are and how important this topic for our discussion. I hope we shall have another moment when we have more discussion and more evidence coming in as regards management of refractory PPH. And I hand over back to Jennifer to take over in the next session. Thank you.
Thank you very much for all of
Sorry. So sorry, Don, I couldn't get my
Yeah,
video
yeah.
on. Thank you for covering. I want to say a special thank you to our interpreters, Glenn and Raul, and Sam and Don for our facilitating today. And of course, thank you so much to all of our speakers and your important work in saving women on PPH. We had many wonderful questions we did not get to. You've asked in the question box about what happens next. We'll be sending out the recordings as well as the slides and we'll give our speakers an opportunity to respond to your unanswered questions as well. And we'll send those all out next week. Next slide. So I hope you enjoyed today's webinar. We will be having our fourth now annual PPH Community of Practice meeting in November 5th and 6th. We are focusing on acceleration of the roadmap for PPH, and we hope that you would join us. On day 2, we're actually having a deep dive into refractory PPH management with responses other than just devices, and we will include country examples, so please enjoy us. Next slide. Finally, if you've enjoyed today's webinar and you want to participate in the community, please join the global PPH Community of Practice and be a voice for change, saving women's lives globally. Thank you so much.
Thank you. Thank you, Jennifer.
Thank you very much.